Hi, everybody. Thank you so much for joining us today for another edition of What's New in Addiction Nursing. I'm Nicole Cowan. I'll be your moderator for today. And I'd just like to introduce our presenter, Emily Poulson. Emily is a registered nurse and a fellow in the BCCU CSU Interdisciplinary Fellowship Program. For the past 3 years, she's worked as a clinician at the Dr. Peter Center in the IOP program and has participated in quality improvement and education initiatives across the organization. Her clinical focus is on working with marginalized groups with complex health issues and substance use concerns in community settings. Her goals of the program are to enhance her skills in leadership, program development, and evaluation of harm reduction, drug treatment, and recovery-related services. She's very interested in learning about evidence-based practices, which she can bring back to her organization in order to improve health outcomes for her clients. Emily is a very passionate advocate for health equity and harm reduction at every level of the healthcare system. So thank you, Emily. I'll hand it over to you.
Hi, everyone. Thanks for joining. The topic I'm going to talk about today is the new world of virtual care, exploring practices for virtual prescribing in Canada. Before I begin, I'd like to respectfully acknowledge that I am a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And in light of the topic being presented today, I wanted to highlight the importance of acknowledging not only the history and the stewards of the lands that we as experts occupy, but also to consider the lands occupied by those who we are serving, particularly when those places are geographically distant and culturally distinct. The learning objectives for today are to review the available literature for OAT prescribing, discuss the benefits and challenges of virtual OAT prescribing in Canada, have an update on the current landscape of programs, and consider the future directions in addiction medicine. The outline will talk about the background of COVID and the opioid epidemic, followed by a literature review. I'll talk a bit about virtual care specifically for rural and remote communities, patient and prescriber perspectives on virtual care, equity and the digital divide, a brief overview of the existing virtual programs, and we'll finish by talking about the challenges and future directions. So, COVID and the opioid epidemic in BC. This is a graph that may be familiar to everyone. It's from the BC Coroner's Service illicit toxic drug deaths in BC from January 2012 to October 31st, 2022. As you can see, there's a sharp increase in opioid-related deaths during the first 2 years of the pandemic. And this is just to highlight that COVID exacerbated an already devastating public health crisis and created new challenges for the provision of addiction care. We also know that access to OAT saves lives. Opioid agonist therapy, which is evidence-based opioid substitution therapy such as buprenorphine and methadone, is the gold standard for treatment of opioid use disorder. And there's many reasons for this, including predictable dosing with no contamination, regular interactions with healthcare, connection to services. And we know that retention in OAT is associated with substantial reductions in the risk for all-cause mortality, and overdose mortality. And as you'll see, retention in OAT is what most of the studies today will focus on as an outcome. And this is because we know that it is, because it's easy to measure and we know that it's important. It's also important to note that cessation of OAT for people already enrolled in care poses significant risk for overdose. And this presented a pressing issue during the lockdown for providing care for our patients that were receiving opioid agonist therapy. So in order to provide continuity of care for people who use drugs during the pandemic, we saw a lot of innovative service modifications focused on adapting programs to use virtual services. And it's not surprising that we saw a 20-fold increase in telemedicine during the first 2 years of the pandemic. A scoping review on early telehealth innovation during COVID reported on the expansion of virtual health services into street outreach programs, correctional facilities, harm reduction sites, as well as the widespread transition to virtual care at existing substance use programs. A key factor underlying these service innovations was the relaxing of restrictions for virtual OAT prescribing in both Canada and the USA. And it's worth noting that it is a slightly different context in both. In the USA, there is an act called the Ryan-Haight Act, which prohibits providers from starting new patients virtually. This was modified during the pandemic so that providers could prescribe buprenorphine, but not methadone, and that's slightly different in Canada. We can provide both. So as you'll see, a lot of all of the American studies focus specifically on buprenorphine as an intervention. In BC, we saw the publishing of the risk mitigation guidelines from the BC Centre for Substance Use, which outlined guidelines for prescribing of safer supply of hydromorphone or dilaudid 8 milligrams, as well as stimulants and benzodiazepines. And there's also the CRISM guidelines for telemedicine and OAT prescribing, which provided guidance for new OAT starts to be completed virtually. And it provided guidance such as physical examinations not being required or could be completed in due time. And urine drug screens are recommended, but not necessarily required for carries. And these policy adaptations have set a new stage for the provision of OAT care, which is the potential to bring lasting changes and improvements to the delivery of more accessible and equitable care. And although social distancing protocols have eased, these virtual care innovations are here to stay. And therefore, it's important that we as providers understand the implications of these modifications in order to guide program development and patient engagement. For the purposes of this presentation, I'll define virtual care as any interaction between patients and members of their circle of care occurring remotely using any form of communication or information technologies with the aim of facilitating or maximizing the quality and effectiveness of patient care. So in this presentation, I'm focusing on virtual care for opioid use disorder and specifically on opioid prescribing. But it's worth noting that virtual care has the potential to increase access to all addiction services, and there is a need to examine this technology's used to support the integration of medication interventions with psychosocial interventions and mental health care in general. So what do we know so far about virtual care? There's some emerging data pre-pandemic, including a systematic review from 2019, which examined telemedicine interventions for substance use disorders. And they concluded that retention and opioid agonist therapy delivered via telemedicine was either similar to or better than in-person care. So just taking a closer look at some of these studies that were reviewed, as you can see, they were all retrospective chart reviews with fairly small sample sizes. 2 out of 3 looked at buprenorphine only. 2 of them had 1-year retentions, which is actually quite a bit longer than what we'll see in the post-pandemic studies. And the results showed in the first study that treatment retention at 12 weeks was 57.4%. And although they didn't have a comparison group, this is comparable to other findings in the literature. And the study was also repeated with a much larger cohort with similar findings. A Canadian study from Ontario found that the telemedicine group was actually more likely to be retained in treatment compared to in-person, 50% versus 39%. And the third study found no significant difference between the groups for any outcomes. This is a retrospective cohort study that compared in-person and telemedicine that was published after that review, but before the pandemic. And it was quite a large study, looking at almost 56,000 patients. And they found no significant difference between the groups for all-cause mortality, 1-year treatment retention, opioid-related ER visits, and hospital admissions. And they reported their 1-year treatment retention rate was 35 to 40%. And this is quite a bit lower than what has previously been reported in the literature, which is approximately 50% as you saw before. And the authors attributed this discrepancy to the increased availability of buprenorphine during the study period. This group did a subgroup analysis of retention rates for buprenorphine versus methadone, and they found that the buprenorphine average retention was significantly shorter, 35 to 60 days compared with 350 to 400 days for methadone. And so taking a closer look at this finding, for buprenorphine, they actually found that the telemedicine group had significantly lower retention rates than in-person. And the opposite was seen for methadone. And this finding is relevant because all studies that we'll look at post-pandemic found the opposite. They saw that buprenorphine showed either the same or higher treatment retention when delivered via telemedicine. However, it's difficult to elucidate this discrepancy because there's no other studies I could find which compared the retention rates of buprenorphine and methadone for in-person and telemedicine. So this is definitely an area for future research. It's also worth noting that in general, we see a very wide range of variability for retention rates of buprenorphine and methadone. This was a meta-analysis that looked at 10 randomized control trials with 4 to 6 month follow-up periods, and they reported that rates of buprenorphine retention anywhere between 20 to 80% and methadone 30 to 83%. And you'll see across the board, especially in the post-pandemic studies, we see a really wide range, which can make these results somewhat difficult to interpret. So taking a look at some of the data from post-pandemic studies, here there are 5 kind of key studies, and as you can see, there's only one prospective study, which also was non-randomized. And these are all American single-site studies, and there's quite a wide variation in terms of the population. They all have small sample sizes, and all of them looked at buprenorphine. There's also quite a variation in terms of treatment retention, especially because these are more recent. Generally, there's only 2 months to 1 year follow-up available. However, so there's a lot of variability in these results. However, these studies taken at face value point to at least an equivalent, if not better, retention rate with telemedicine. And this conclusion is supported by a scoping review, which looked at 69 studies between 2008 and 2021, looking at both pre and post-pandemic data. And it also included commentaries, editorials, letters, and online resources. And they concluded that incorporation of telehealth technology with medication-assisted treatment for opioid use disorder is associated with higher patient satisfaction, comparable rates of retention, and an overall reduction in healthcare costs, and an increase in both access to and usage of buprenorphine. So going back to the limitations, we've kind of already talked about some of these, but as we saw, they're mostly single-site studies from the USA. Most of the data comes from non-randomized retrospective cohort studies with short and inconsistent follow-up periods. Many of the studies lacked a control group, and there's heterogeneity in how telemedicine was deployed, the population being studied, and the study outcomes. And as well as we saw, most of the studies focused only on buprenorphine, which we now know may not necessarily be generalizable to methadone and quetiapine. When talking about the limitations in non-randomized studies, it's important to think about the risk of bias, and in this case, the potential for selection bias. So patients in the telemedicine group may have been selected into the telemedicine group based off of characteristics that were not accounted for in the results. And this presents confounding variables that may bias the results of the study. And some examples of these differences that could exist between these two groups at baseline is the severity of opioid use disorder, socioeconomic status, polysubstance use, concurrent disorders, and probably many more. However, very few of the studies accounted for these potential selection bias, and most only looked at sex and income, which may not be adequate to account for many of the important differences that may exist. And so when thinking about the selection bias, it's important to consider which way this may have biased the results. And as we'll see later, there was a widespread prescriber hesitation to take on new patients virtually. And this is due to an overall lack of good efficacy data and safety data. And so prescribers may have been more likely to take on patients virtually that they deemed appropriate, such that patients, since the telehealth group may have been more stable at baseline. And if the speculation is true, this would potentially bias the results toward increased retention for telehealth. However, we really need randomized trials to show this. So the take-home message here is just that these conclusions should be taken with a grain of salt until we have data from randomized control trials to support it. So areas for future research. We need to see more adequately powered prospective studies with randomized control groups, studies examining outcomes such as quality of care, psychological, societal, and economic impacts, studies which examine the harms associated with telemedicine. And this one is particularly important because the studies so far have only really looked at retention rates and very few have reported on adverse outcomes. So this is a major gap, an important gap in the literature. We also need to see more subgroup analysis of subjects to further examine differences in uptake and outcomes between different demographic groups, because as we'll see later, telemedicine has the potential to create a digital divide, and this should be addressed in the research. So done with the lit review, and now I can talk about some of the more interesting stuff. So there's a really important role for virtual health in rural and remote communities. We know that rural and remote communities are disproportionately impacted by the opioid pandemic and experience greater difficulty accessing help. We know that there's an increased incidence of opioid use disorder and opioid-related deaths, an increased incidence of opioid-related ER visits and hospitalizations, and patients living in these communities are less likely to be enrolled in OAT treatment. So this is an integrative review published in 2021, which highlights some of the barriers and facilitators to care for rural and remote regions. Some of the barriers that they reported was geographical distances to clinics and pharmacies, limited seasonal accessibility, chronic shortages of healthcare professionals, and poor access to psychosocial supports. On the other hand, facilitators was care which was contextually focused on community support, culture, and social restoration. And so while telemedicine was seen as an important innovation to mitigate some of these barriers, OAT programs in rural settings should not be limited to the patient-prescriber dyad, basically just meaning that it should not overlook the role of the social and cultural context of the community, and this is particularly important in First Nations territories. So this is a map that comes from a retrospective cohort study looking at the use of telepsychiatry for opioid use disorder in Ontario. And they show here that the median distance of a recipient of care to their opioid use disorder prescriber in Ontario is 341 kilometers. So huge distances. And we can imagine that in BC, these distances may be similarly quite vast. And the implication here is that while telemedicine is a hugely valuable tool to provide care for rural and remote regions, communities may differ greatly in terms of the social, political, and economic context. It's important for providers to have an understanding and a relationship with these communities in order to provide care which is culturally safe and adapted to the geographical, cultural, and institutional circumstances of the communities that they are serving. So virtual care, patient and provider perspectives. There are 3 qualitative studies looking at prescriber perspectives on virtual care, and they highlighted some key themes. Some of the benefits they reported was flexible work hours, that video calling can create context and a glimpse into the patient's lives. Anecdotally, they reported improved appointment attendance. On the other hand, some of the challenges was less structure and accountability, and less information to guide clinical decision-making because they have to rely more on patient report than objective assessment. There can be issues with technology, overall shorter visits, and some reported less intimacy, especially with phone calls. There are other themes that arose from these studies was changes in care patterns. So overall, we saw less urine drug screens and lab requirements, fewer visits, and greater quantities of opioid medications being prescribed. And without a lot of safety data and efficacy data, we saw a pretty widespread hesitation for providers to take on new patients via telehealth. There was a survey in the United States that showed over 10,000 physicians, and they showed that only 33% of them were willing to take on new patients virtually despite relaxed restrictions. And although these are American studies, I don't think it would be a stretch to imagine that these concerns exist amongst Canadian providers. And this can have unintended consequences for treatment equity, which I'll discuss later. So overall, in all 3 studies, prescribers express the need for more guidance to start patients virtually. From the patient perspective, there was a scoping review of key implementation factors that did that summarized some of the patient perspectives in the papers it reviewed. And they reported in general very high rates of patient satisfaction, increased convenience and reduced wait and travel times, decreased stigma and anxiety about new surroundings and crowded wait rooms, on-demand and same-day starts. On the other hand, some of the challenges were issues with access to technology, reliable internet, and safe places to have phone calls. Some reported a lack of comfort and just general distrust with technology. And another consideration is that a lot of people rely on OAT clinics for clothing, food, and harm reduction supplies. So with virtual care, they have decreased access to these basic resources. This next topic, I think, is one of the most important ones I'll talk about in this presentation. It's called Virtual Care and the Digital Divide. So pre-COVID, we know that Black, Indigenous, and people of color who had opioid use disorder had worse health outcomes and were less likely to be receiving care. And this difference has only been exacerbated during the pandemic. There was a 2021 scoping review examining the impact of COVID on healthcare delivery for people who use substances, and they showed a disproportionate increase in overdose deaths for minority groups. There was one study in California that reported that fatal overdoses increased by 60% for Black Americans, while it actually decreased for white individuals. And there was another study that showed that African American persons had a lower odds of receiving opioid use disorder services, as well as lower odds for opioid agonist therapy retention. And although these are American studies, in Canada, we see disproportionately worse outcomes for Indigenous Canadians. This is a graph from the BC Coroner's Death Review Panel showing that First Nations people are disproportionately represented in deaths due to illicit toxic drugs. As you can see, Indigenous people make up 3.3% of the province's population, while they represent 14% of the overdose deaths in that second year of the pandemic. And we also know that they're dying at 4.8 times the rate of other BC residents. So the health inequities experienced by Indigenous people in Canada reflect structural and systemic disadvantages that were created through colonization. So when we're looking forward to creating potentially new systems through virtual care, it's important that we don't recreate these same structural and systemic disadvantages. Because as we'll see, this can happen unintentionally. So I'll just explain a little bit more about how COVID can create this digital divide, specifically in addiction care. We know that during the pandemic, because of the lockdown, we saw capacity and infrastructure limitations, which led to a decrease in new intakes for opioid use disorder treatment in both Canada and the United States. And as we discussed, there was prescriber hesitancy to take on new patients virtually. We also know that white people who use drugs were more likely to be in treatment at the start of the pandemic, and therefore were more likely to maintain access throughout. So what we get is that there's decreased barriers to care for people who are already receiving treatment, leading to better outcomes, while for others, COVID made it more difficult to access care for the first time. And the effect is an increase in outcome disparity. In addition to this, we know that racial minorities are more likely to have lower digital health literacy and lack access to technology, internet, and stable housing. So the take-home message here is that virtual care can reduce barriers, but not equally for all. And this can create what we call the digital divide. So how do we address this? We need to prioritize minority groups and provide low barrier access when designing virtual care services. And we've already seen some really great innovative solutions that have been implemented, such as phone booths at harm reduction sites, Zoom technologies in local pharmacies, and mobile technologies for street outreach, as well as 24-hour hotlines so that people who lack access to technology are able to get access to treatment providers. We also need to see more evidence-based guidelines to support physicians to feel comfortable in taking on new patients virtually. And this requires research supporting both the safety and the efficacy of exclusively virtual care. Thankfully, in Canada, we have some really great examples of low barrier programs that demonstrate that patients can be started virtually, and that virtual care, if implemented thoughtfully and in the right settings, can increase access to hard to reach populations. So in this next session, I'm going to talk about some of these telehealth solutions, and we'll see some incredibly innovative programs that have arisen out of the pandemic and which are really changing the landscape of opioid use care in Canada. And I want to acknowledge that a lot of this information was very generously provided by the virtual care teams at each of the health authorities who took the time to speak with me about their experiences building these programs from the ground up. And as you'll see, they've each taken slightly different approaches based on the needs of their region and created services specifically designed to address gaps in care. The first one I want to talk about is Alberta's Virtual Opioid Dependency Program. And this program was started before the pandemic and has really acted as a model for all of the programs that have come after it. And so I'll take you sort of through a trajectory of what this has looked like. So in 2017, it was a single site pilot project. And by 2018, it had expanded its services to the entire province. In 2019, still before the pandemic, they added 2 new services, including a same-day emergency start service and a transitional treatment team for bridging care, while continuing to provide ongoing management for patients who are not connected. In 2020, during the pandemic, they added brief counseling interventions, including motivational interviewing, and then continued to expand services, starting to work with correctional facilities to support high-risk clients leaving the system. And they made this team official in 2022 and called it the Low Barrier Urgent Access Team. So as of 2022, Alberta is providing the Virtual Opioid Dependency Program is providing 85% of all of the prescriptions for opioids in Alberta. So it's just a really good example of how these programs can be so scalable. And the way the program works is that there's assessment and medication prescriptions, which are managed by physicians out of a central office in Ponoka, Alberta. And they collaborate with local communities all over the province for laboratories, psychosocial supports, and pharmacies for supervised dosing. And as you can see, there's telehealth endpoints all over the province, including the northernmost regions. Going back to the Low Barrier Urgent Access Program, I just want to highlight the importance of this just to show how we can reach vulnerable clients, especially those being released from the correctional system who we know are at very high risk for overdose. Since starting this program, they have 520 active clients in the second quarter of 2022-2023. And as you can see, 3/4 of these referrals come from police services. This program published some of their results with data from before the pandemic, and they showed comparable treatment retention to other studies, 90% at 6 months and 58% at 12 months. They showed a decrease in polysubstance use, accidental and intentional overdose, improved social functioning, high client satisfaction, and an increased service utilization over time. So they were kind enough to share with me some more recent results from 2021-2022. And this is showing in the top right, the increased service utilization, starting with 211 new admissions in 2017-2018, and now in 2022 had 4,085 new admissions. They are supporting 331 communities since they started, and throughout the program, we're seeing high client satisfaction. In terms of client relevant outcomes, this program is showing significant decreases in substance use at 3 and 6 months, as well as a decrease in accidental overdoses. And again, this is from data from 2021-2022, so post-pandemic. This is from the Methadone Same Day Start program, and I'm not going to go through all of it. I really just wanted to highlight this one point, which is that 30% of people who are discharged from the program get readmitted. And this is important because it shows us, we know that when we're working with people who, the most vulnerable populations, there tends to be very high attrition rates. But if we have sufficiently low barriers and the opportunity for self-referral, a lot of these patients will come back. So the conclusion here is that efficient virtual care systems have the potential to be both scalable and equitable and expand access to vulnerable and hard to reach populations. In BC, the First Nations Health Authority started a virtual substance use and psychiatry service, which was launched in August of 2020. And it was designed to provide culturally safe specialty substance use and psychiatry services to all First Nations people living in BC. So going back to the earlier point about the need for culturally safe services, which are designed to enhance community connections, this is a really excellent example of a solution that combines telemedicine with culturally safe and contextually relevant care. In terms of their workflow, their referring provider plays a key role in appointment and care planning. And what makes this program unique is that this referring provider is present on the phone call with the prescriber in order to facilitate care coordination and continuity of care. And if this patient doesn't have access to a provider, they can use the virtual doctor of the day service to get connected. Vancouver Coastal Health and Providence Healthcare this fall launched their virtual RAC, so the Rapid Access Addiction Clinic on the Sunshine Coast, and it's called Lighthouse Clinic. And this is to offer short-term stabilization and connection to local communities across the whole VCH region. And these referrals can be self-referred from the emergency room, acute and community services, as well as short-term custody. And their care team, similar to the St. Paul's RAC, is made up of physicians, LPNs, social workers, a clerk, and soon they're going to add a peer navigator. So this is just showing the Lighthouse referral pathways. So similar to the VODP, it offers multiple pathways, including same-day starts, transition and bridging services, as well as longitudinal care for patients not connected. And they are able, they approach labs and ECGs and UDSs on a case-by-case basis for patient-specific needs. And the Sunshine Coast has an overdose outreach team that can assist with getting clients to the lab if necessary, and they can also help with referrals. And so this program right now is just on the Sunshine Coast, but they have plans to expand to the whole VCH region. At Fraser Health, during the pandemic, they launched the Virtual Health Addiction Clinic to support outreach teams in Fraser Health. And that has since expanded to a virtual inpatient addiction medicine consult team that can be accessed by any hospital in Fraser Health that doesn't have its own AMCT. And it's run out of a physical location in Creekside, Surrey. They have a full-time staff team made up of a clinical coordinator, an MOA, an LPN, and 2 physicians. Interior Health has a really cool program. It's called the Virtual Access Medicine Service, and it started in October 2021 as an essential intake service for referrals from ER. Interior Health has approximately 30 communities that each have their own OAP programs. However, only 2 of those are able to take patients on next day referrals. So what's happening is that the emergency room would start people on opioids, on opioid agonist therapy, but they had nowhere to refer them. And so patients were being lost to care. And so this service started as a bridging care program to meet this need. So how it works is that it leverages nurse prescribers who will call the patient the next day, write a bridging script, submit the Plan G for pharmacare, and then these patients are followed virtually or followed by virtual care until they have their intake with their community provider. They are prescribing right now primarily Suboxone, and that's because they received an exemption for Suboxone to be dispensed directly from the ER, so further reducing the barrier of having to go to a pharmacy after discharge. But they will also provide Cadian and methadone scripts if needed. Right now, they're not doing any safer supply or risk mitigation prescribing, as they're leaving this up to the primary care provider's discretion. So results so far, they have done 247 emergency department starts from June 2021 to December 2022. Despite this, and so 50% of the referrals from the program make it to treatment for at least 30 days, and there's 37% at 90 days. However, approximately 50% of patients are still being lost to follow-up. And this just speaks to the need for self-referral to give patients that opportunity to reconnect. Because as we saw with the VODP, 30% of patients who are discharged will actually get readmitted. So they are looking, right now, it is only referral through the emergency department or other substance use centers. However, they're looking to move towards self-referral and even integrating texting-based services to connect with clients in the communities. As of this year, Interior Health is, the virtual program is providing 43% of the OAT prescriptions for Interior Health. At Northern Health, they've also opened an exclusively virtual program, which is low barrier, culturally safe and equitable. This again was designed to meet some gaps in care. A lot of the Northern communities in BC, a lot of the communities in Northern Health do not have OAT providers. So they targeted a population that was not connected to substance use services or experiencing significant delays or interruptions. And it's a fairly new program. So prescribers right now are only available 3 days per week, but they have nursing assessments available 7 days a week from 10 a.m. till 10 p.m. And they shared a report of some of the experiences of the nurses, the staff, patients, and community providers, showing what their experiences so far. And we see a lot of the similar benefits that we saw in the studies earlier, including timely access, ability to work remotely, and capacity building. So hopefully their program will continue to expand. And finally, Island Health does not currently offer any exclusively virtual services. However, OAT clinics are offering a combination of in-person and telephone follow-up. So to summarize, some of the benefits that we've seen in virtual care for opioid use disorder is the elimination of geographical barriers to OAT, including increased access for rural and remote communities, access for hard to reach populations such as street outreach and correctional facilities. There's protection against stigma associated with accessing in-person services, immediate or real-time access from anywhere, as well as reduced or no wait times. On the other side, the challenges can be in verifying patient self-report due to the inability to do physical health assessments. And this can lead to hesitancy for prescribers to take on new patients. Telehealth also requires patients to have access to technology and Wi-Fi, and we know that people who use drugs are more likely to have frequent turnover of mobile phones, lack access to smartphones and service plans, internet supporting video calling, and access to private locations, which can potentially increase the risk for the digital divide and worsening disparity. Right now, there's an overall lack of available data with regard to safety and efficacy to guide program development and clinical decision making. Hopefully going forward, we get some more data for that. As with any virtual care, there's potential for workflow interruptions, internet disruptions, and poor connectivity. And depending on the perspective, there can be a loss of personal connection, although for some patients, they actually prefer the anonymity. So I just want to take a moment to talk about this really challenging subject. This came up a lot when I was speaking to the different health authorities in terms of how they're managing risk mitigation prescribing in BC. It presents like some uniquely challenging, some unique challenges for virtual care specifically. So safer supply or risk mitigation prescribing is hydromorphone or dilaudid 8 milligrams, and which is right now not considered an evidence-based OAT therapy. And we know that it's high risk for diversion because it's dispensed as a carry and because it's short acting. And so there's community concerns that safer supply might be contributing to increased incidences of opioid use disorder, particularly among youth. It's worth noting that right now there are no studies. There are no evidence to directly link safer supply with new opioid use disorders or Dilaudid as a gateway drug for youth. There are also no studies that described diversion or misuse as notable outcomes in adopting more lenient take-home policies or virtual prescribing. This doesn't mean that this isn't happening. It just means it's just right now that we don't have the data to support it. And given this context, there's a lot of disagreement amongst providers within programs and also between different regions. So this can create challenges for virtual care in terms of developing prescribing protocols, and also can create tensions when trying to transition a patient from virtual care back to their community provider. So the take-home message here is really just that it's important to consider the concerns and wishes of the communities being served in order to preserve positive and collaborative relationships with local communities. So considerations for virtual care. What existing local resources are available in the communities being served? How can we prioritize building relationships and tailor services to community needs? How do we approach providing care for Indigenous clients and their communities in a way that is culturally safe? i.e., how do we avoid recolonizing these communities with Western addiction treatment? How can we manage ongoing relationships with primary care teams in geographically distant locations where the prescriber may not be familiar with the social and political context? How can we mitigate potential downstream risks for introducing safer supply into new communities? How can we integrate psychosocial interventions along with OAT? Can we include referrals? Can we include referral services or brief interventions for virtual care through virtual care? How do we create services which are both scalable and equitable? And finally, how do we design services which close the gap in health outcomes rather than widen it? So hopefully this gives you guys some things to think about with regards to virtual care. And now I will open the floor for any questions. Thanks so much for listening.
Oh, sorry, my camera working. Thank you so much, Emily. That was just a wonderful presentation. Yes, we'd just like to invite the audience to just enter your questions into the chat. So we have one question here. Did you have any findings related to the use of text messaging to deliver care? Great question.
Yeah, so there are a few programs using it. Right now, so far, I've only heard of Interior Health integrating it, but generally I think the use is that allied health and social workers would be able to connect with clients via text message. I mean, there's ongoing concerns about kind of privacy and safety. So right now in Canada, I don't know if any of these programs are using it, but certainly it's something that they're looking at.
Great. Was there any mention of sort of impacts to resources when you're going through the literature?
I guess that is sort of like economic resources.
Mm-hmm.
And there is some, just hopefully that's what you were meaning by that. So initially there is like quite a substantial cost associated with getting the technology and developing the program. However, long-term, some studies are showing that it may be overall cost-effective. But because a lot of these programs haven't existed for very long, we don't have a lot of good longitudinal data. So it's definitely something that we'll hopefully learn more about going forward. But in terms of like human resources, I think it's actually been quite effective because you can have physicians and nurses working out of any region to provide access to care sort of on an as needed basis. So yeah, lots of implications for resources, but that's certainly an area for future research to actually get better answers.
Great, thank you. Is there any other questions coming from the audience? We still have a few minutes. It's really exciting to hear about all the work that's going on across the country and locally within the province too, to extend virtual care services. And really exciting to hear about how nurse prescribing has been embedded within those programs as well. Considering, just in our current context, some of the challenges with meeting the needs of a large population with limited resources, staffing resources as well. So it's really great to see, how all these teams are working together, finding new innovative ways to reach people and deliver care, especially in remote communities.
Yeah, no, certainly a lot of really creative solutions, and hopefully we'll start to get some data on how these things are working in the times to come. A lot of these are still brand new. So, a lot of people kind of working in the dark, trying to do the best possible with pretty limited knowledge. But it seems so far that there's been some really good uptake of these programs, which is, looking really good.
Yeah, it's exciting. Well, thank you so much for your presentation and all the work that you put into reviewing the literature and scoping and that. And I would just like to, we have one more question. Sorry here. Was there any data with times related to clients who have a substance use disorder who are being seen in the ER for prescriptions of medications for withdrawal not related to the visit?
Sorry, can you repeat that again?
Yeah, let's do it again. Oh, okay. So if they were being seen in the emergency for prescriptions, I think not for withdrawal, but not related to the visit. Yeah, I don't know if that.
Yeah, I think like we don't really have data on that, because really it was just like most of like the studies were like retrospective cohort, and they really didn't do much of a breakdown. In terms of what I mentioned about interior health, these ED starts, that data that I was showing, that like 30%, those are all ER visits. So I think I showed that, I think they said there was 247, and 50% of these starts make it to treatment for at least 30 days. So, and I don't think that these are anything like necessarily that these patients were specifically going to the ER for substance use treatment. I think these are just any patients that received a prescription for Suboxone or another OAT medication while they were in the hospital and were followed afterward through this virtual care service. Hopefully that answers your question.
Okay. All right, great questions. Okay, so I don't see any more questions coming from the audience, but of course, sometimes there's questions that are coming to mind afterwards. And if there's anything that you would like to reach out and get clarification about after our session today, please just reach out to us and we can connect you with myself and Emily for any further questions.
Okay.
Oh, sorry, there's one more question.
Awesome.
Yeah. So in interior health, we found that 34% of the ED visits resulting in Suboxone starts were for reasons other than substance use. Okay, so just very interesting stat there. Okay, so maybe for maybe there's some starts for pain control in that as well.
Yeah. So I don't think they did the breakdown of the data to say whether patients were started, like whether patients went to the ER specifically for opioid related issues or whether they were admitted for other issues and then started. I think they didn't really specify in between. It's really just any of the patients, to my understanding, that went there. However, I think like this information was provided by one of the clinical coordinators for the program. So if he's okay, I can probably share his information because he is a really great resource to talk about how these things are working, and I don't want to say anything that's incorrect about how their program is operating.
Yeah, good. All right. Well, thank you so much, everyone, for joining today. Yeah, just reach out if you have any other questions for us. And thank you very much, Emily. Wonderful. All right. So have a great day, everyone. Thank you so much for joining us. Bye for now.